So welcome to the Brain Tumour Foundation of Canada Research Symposium. I have gone in for the most part and gone in and muted everyone, but if you haven't muted yourself, I do ask that you do please, just so that we can't hear what's happening in the background or phones going off or anything. And if you just hover over to the right-hand corner of your picture, up at the top, you can just click and it says mute and unmute. I will ask that you stay muted the entire presentation. Any questions that people have throughout the presentations, you are able to provide those down in the chat option. I am getting a couple messages, so I'll help with some of kind of the housekeeping that I can at the beginning before we get started. But anyone who is having issues with audio, you can either connect through your computer audio, or you can connect by using the call-in phone numbers that was in the email. So if you're having difficulty with the audio on your computer, that is an alternate solution for you. So to kick things off, I'd just like to mention to anyone who might not be aware that this is the beginning of Brain Tumor Awareness Month. So this is day 2 of turning May gray, and I'm sporting my gray today, and we hope to see lots of people sporting gray throughout the month of May, as well as sharing on our media outlets and through our social media different things that you might be doing to bring awareness to Brain Tumour Foundation of Canada. Again, for anyone who's new to joining us, if you can please mute your mic, that would be great. In the right-hand corner, you can do that so that we can't hear your background. Today, we are obviously supposed to be having this live in person in Calgary. Obviously, due to the change in our world, we've needed to accommodate accordingly. And so I thank you all for joining us. I also thank the speakers who are joining us today that are still able to commit in this modified format. So thank you. Things that are happening right now at Brain Tumour Foundation of Canada, we've got a lot going on. I'll name just a few, but I would encourage you to check out our social media as well as our website to include everything. And if you have questions, again, include those in the chat. And I see that there are some items in the chat already, and I will get to those as soon as this intro is done. I spoke about Brain Tumor Awareness Month, so we're excited about that and the launch. We're encouraging everyone to share stories, follow us on social media, be an advocate out there, and really help us raise awareness about Brain Tumor Awareness Month. As well, our Brain Tumor Walk has gone virtual, so we've had to make some changes in that as well. We still want to see that program move forward. We still want to see people coming together and raising funds to continue to support those in the brain tumor community. So we have a 27 Canadians challenge. If you haven't checked it out, please do check it out. Register yourself, register a team. The kind of background of that is that 27 people today will hear the words, "You have a brain tumor," and we're asking those who are registered for this event to ask 27 people to give you $10 or to, get some sort of different variation of funds. When you reach $270, we will send you a buff that you can take a picture of and use those hashtags of Brain Tumor Awareness Month or Turn May Gray. What other things do we have happening? Our virtual support. We have a new support at home program, again, taking a lot of the things that we are doing and turning those virtual. So please do check those out. We have some great programs that our programs and services team is working on. And you would be amazed to see what things we can do virtually in this world. The education awards are coming up for brain tumor recipients. Brain tumor students who are looking to pursue their post-secondary education who have been affected by a brain tumor. So if you haven't checked those out already, or you know someone that might benefit from that, that closes May 22nd, so there's still time to apply for that. As well, we have some great resources, as we always have, as well as a new caregiver resource. We have a upcoming webinar on May the 27th, which is Personal Stories of Hope. So it's a great time to, hear other stories and hear those who are affected. So those will all be happening as we're moving forward, and as always. And the last thing, again, just a quick note again, if you haven't muted your microphones, to please do so. I hate to be a broken record, but that way we don't get to hear everyone's backgrounds. And speakers, when it comes your turn, please remember to turn your microphone on. Again, the questions can be asked in the chat. Each of the speakers will have a few minutes at the end of their presentation to answer those, and they'll just read them through the chat, or I will read them aloud. We'll see how that works out in this new virtual format. And in terms of the flow of the presentation for the speakers, I believe that we'll have all four of our speakers today. Sorry, I'm just gonna mute someone here. There we go. All of our speakers, I believe we only had one that was unable to join us. So I believe that we'll still have four. So we'll cross our fingers that everyone's able to get online and join us. So without further ado, I'd like to introduce Emily Walker. Each of the presentations in the presenters have been asked to do a little bit of an intro at the beginning, just to help with the transition between speakers and myself. So I will pass it off to Emily to take it over. So Emily, it's all yours.
Hi everyone. I'm just going to share my screen here. There we go. Okay, so my name is Emily Walker. I'm a cancer epidemiologist. I work with the School of Public Health at the University of Alberta, and I'm going to be giving you a bit of an overview of the Brain Tumour Registry of Canada today. So I'll start out with a background on cancer surveillance in Canada, why we need cancer registries, what we do with this data, how brain tumors fit into this picture, and what the Brain Tumour Registry of Canada is. Then I'll go through some of the data improvement initiatives that we've done to date and what we're planning to do next, and some of the highlights in terms of the incidence and survival among brain tumor patients in Canada. So to start, Canada has a well-established cancer surveillance system. So each province and territory has a registry and is mandated to collect data on all cancer diagnoses occurring within their geographic regions. And they submit this data to Statistics Canada on an annual basis for inclusion in the Canadian Cancer Registry. So this is a passive surveillance system, which means that data are collected as part of routine diagnosis and care, and patients are neither required or able to register themselves in these cancer registries. And this is an important thing to note because it is an effective strategy for making sure that we have complete data on all of the cancer diagnoses occurring in Canada. But of course, it relies heavily on there being cohesion between the ways that reportable tumors are managed clinically and the mechanisms for getting the data into the cancer registry. So something to keep in mind. Why do we need cancer registries? Well, they provide population-level disease surveillance. These systems collect data that lets us describe cancer burdens and trends. And this is really fundamental to supporting health services planning. So it's the backbone of a well-functioning healthcare system is effective surveillance. So we can use information on the burden of cancer in the population to design and evaluate cancer programs and to predict future burden so that we can plan for the health system capacity to manage that burden. And of course, the data itself can be used in research studies. So we want to develop hypotheses around demographic risk factors for cancer. And it creates a cohort, which is a group of people with a common characteristic that can be used to design other types of research studies on causes, treatments, quality of life, any number of things. So really valuable resources to have, important to have the high quality data. Sorry. So how do brain tumors fit into this? Well, cancer registries are certainly mandated to collect data on brain tumors diagnosed among Canadians, and malignant tumors have been routinely captured in these systems since their inception. However, brain tumors are unique in that they're the only tumor for which both malignant and non-malignant behavior types are mandated for inclusion in the registry. And this is a relatively new change. It was legislated in 2007 following advocacy efforts from the neuro-oncology community, which really highlighted that because of their anatomical location, non-malignant tumors can be just as devastating, and we need data on their occurrence to support research and clinical decision-making. So even though this change was made in 2007, there remain two issues with the existing cancer surveillance system for the neuro-oncology community. One, although mandated, evidence suggested that non-malignant tumors were not being effectively captured by these systems. And two, brain tumors are an extremely heterogeneous group of neoplasms, but they tend to be grouped together as all brain and other CNS tumors in routine surveillance reports. So that's of limited value for supporting the clinical and research communities. And so the Public Health Agency of Canada completed analysis looking at this, when we compared the age standardized incidence rates of malignant and non-malignant tumors occurring in the US to those diagnosed in Canada. Sorry, registered in Canada. So the malignant tumors are shown in the light gray bar, and we can see that the rate in the US is very similar to the rate in all of Canada and similar to the rates across all of the provinces. Conversely, when we look at non-malignant tumors, and that's denoted by this black bar, we can see that the rate is much higher in the US relative to Canada and relative to most of the Canadian provinces that were included. So if we assume that the rates in the US are similar to those in Canada, which is a reasonable assumption based on comparison with other types of tumors, then we were missing about 60% of the non-malignant brain tumors in the cancer registry. So that's where the Brain Tumour Registry of Canada comes into the picture. So this is a surveillance research collaborative that was established in 2016 with the aim of improving infrastructure for brain tumor surveillance and reporting in Canada. So we work with the existing cancer registry system. That's an important thing to note. It is not a standalone registry. And the rationale for this is that the existing system is well established and sustainable. So we didn't want to reinvent the wheel. We wanted to make the wheel better. So the most efficient strategy going forward from our perspective is to use research to enhance the existing system so that going forward we can make sure that data collection on brain tumors in Canada is complete and ongoing. So I'll just go through some of the projects we've done already and planning for the future to improve the data on brain tumors in Canada, some of the regular surveillance reports we've already produced and plan to produce. So initially we've collaborated with 4 provincial cancer registries to enhance the quality of the data on non-malignant tumors in their registries. So BC and Alberta added supplemental case ascertainment activities to their routine activities for the years 2010 to 2015. So specifically, they added review of the discharge abstract database, and that is a database that includes all diagnoses that occurred during a hospital stay. And it isn't a routine source for them to get data on brain tumors in Canada. And Manitoba and Ontario continued their routine case ascertainment activities, and they kind of ramped up their quality control. So through this process, we identified a lot of new non-malignant brain tumor cases. So here we have on the y-axis the age standardized incidence rate per 100,000 persons, and the x-axis is the province. The blue bars represent the incidence prior to any supplemental case ascertainment activities, and the orange following that. So you can see in BC and Alberta, we really added quite a few cases to the registry, and overall added about between 0.31 and 6.3 diagnoses per 100,000. So quite an improvement. And taking a closer look at the provinces that did these extra case ascertainment activities, in BC, prior to any of the work that was done, we think we had about 37% of the expected non-malignant tumors in the registry. And after supplemental case ascertainment activities, we have now about 69% of the expected cases registered. And in Alberta, same kind of story. Originally, we had about 48% of the expected cases registered, and following activities, we had 74%. So I guess the glaring thing here is that we still don't have all of them. And why is that? So we brought together a huge team of people, including neuroradiologists, neuropathologists, neuro-oncologists, epidemiologists, biostatisticians, cancer registry folks, really trying to drill into why are we missing these people, and how can we efficiently and routinely capture information on those diagnoses going forward. So we really classified brain tumor care into 3 categories. First, we have a patient who is diagnosed, they undergo surgery or is seen by an oncologist initially following diagnosis. These are most likely our malignant tumors, and this is the patient group that the cancer registry system was designed for. So we are confident that those people are going to be included in the cancer registry, and the data on those diagnoses is going to be the most accurate and complete. Next, we're going to have patients who undergo a series of CT or MRI scans. So they're radiologically followed for a while, then they experience some tumor progression, and at that point they undergo surgery or are seen by a neuro-oncologist. And then we think we'll most likely have data on that tumor in the registry, but the level of accuracy and completeness depends on the length of time it took for the tumor to progress. So routinely, tumor registrars will look back in the medical record to make sure that they have kind of an initial diagnosis for a tumor. So if the tumor progressed quite quickly, we probably have data on the original diagnosis and the original diagnosis date, and that's quite accurate. If it took decades to progress, then we're less confident that we have accurate information on the initial diagnosis. And then finally, a patient who is diagnosed and then followed up exclusively through radiological scans. They don't undergo surgery and they're not followed up with an oncologist. We are most likely missing those patients. So again, traditionally, malignant tumors are not exclusively diagnosed radiologically. And so the cancer registry system is not built to capture these types of tumors. So that is where we decided to focus our efforts going forward. And again, really driving in, so once somebody is diagnosed radiologically, what happens to that data? So they undergo a scan. That scan is reviewed by a radiologist. They dictate a text report. Both the scan and the report are then put into an information database. And from there, they can be distributed to electronic medical records, health record systems, but they're not getting into the cancer registry. And we identified some important barriers to that. First, a high report volume. So radiological scans are occurring at a very high volume on a daily basis. Lots and lots of scans, and the reports are unstructured. So it is not feasible for the tumor registrars to manually review all of the scans that are, or all of the reports that are coming out, and trying to read them carefully to identify pieces of information that might be relevant to a diagnosis. There's also a lack of a trigger. So whereas in a pathology lab, there's a trigger system mechanism administratively for them to say a tumor has been diagnosed, this needs to go to the cancer registry, that doesn't exist in a radiology lab. And sometimes the diagnoses are inconclusive. So a radiologist might describe the appearance of the tumor and describe multiple potential diagnoses. So there are a lot of complicating factors that would make it really difficult for tumor registrars to go into the system and identify a tumor using the reports themselves. So what we're proposing going forward is to develop a machine learning solution to this problem. So we want to use natural language processing algorithms to scan through the reports, identify language that is consistent with a brain tumor diagnosis, collate the most probable cases, pass them on to the cancer registry for final review and inclusion in the cancer in the registry. So we think this is the most efficient strategy going forward because it doesn't require radiologists to change the way that they function and do synaptic reporting or something like that. It doesn't require the cancer registries to add substantially to their workload, and computers are certainly more capable of sifting through thousands and thousands of reports than a human. So that is what we would like to pursue going forward, and think that this is the most efficient strategy for making sure we're getting all of the non-malignant tumors consistently in the cancer registry. We want to take it one step further as well. So brain metastases are they're tumors that originate from an extracranial primary tumor, and where they're thought to be the most common type of malignant brain tumor that occurs. However, the data on these tumors that we have in the registry doesn't go past diagnosis. So unless the the brain met was present at the time of the primary tumor diagnosis, it is likely not captured in the cancer registry. And again, that speaks to kind of the report volume and the workload that the cancer registries have. It is not feasible for them to follow up on every single person who's alive with a primary cancer diagnosis to identify whether at some point they developed a brain tumor. So we think we can use the same technology with the machine learning scanning of radiology reports to identify a new diagnosis of a brain met and make sure that that information is captured in the cancer registry. And then further molecular markers, as we learn more and more about the molecular features of brain tumors, we learn about the markers that are really crucial for diagnosis and prognosis. So they're now considered a necessary component for an accurate brain tumor diagnosis, but the information, again, is largely missing from the cancer registry. So as we learn more things in the scientific community, we need a way to make sure that these registries can catch up and capture that information so that they stay relevant to current scientific applications. So again, we think we can use this machine learning approach to scan pathology reports and identify important information that can be added to the cancer registry. So those are our next steps. I think we've been playing catch up a little bit with the US in terms of getting all the non-malignant tumors in there. And now I think we can really push forward and be leaders in the breadth of information that we include in our cancer registry. So that's where we're headed. So to date, we have published several comprehensive surveillance reports. So again, kind of trying to meet that need of not just looking at all primary brain, all malignant brain and other CNS tumors together, really breaking it down by histology and behavior so that the neuro-oncology community gets the information that they need. So this started with a comprehensive report on malignant tumors, and since then we've been able to do a comprehensive report on malignant and non-malignant tumors in the 4 participating provinces, both incidence and survival. Some highlights from those. So based on this information, we have an estimated incidence of 23.5 new cases per year, per 100,000 per year, sorry. And at this point, 64% about of those are non-malignant tumors. And as we mentioned, we still think that we're missing some of those non-malignant tumors, so the proportion of annual diagnoses that are non-malignant tumors is actually likely higher. And as Sue mentioned, we estimate that there will be about 27 new cases of brain tumors, primary brain tumors diagnosed each day in 2021. So just breaking down the proportion of malignant, non-malignant by major histology group, you can see that several of the major histology groups are predominantly non-malignant tumors. So tumors of the cellular region, meninges, and cranial spinal nerves were probably heavily underreported previously. Still a little bit underreported. There's still some work to do, but we've really made some gains in our ability to report on these tumors. And the breakdown of all of the tumors is, of course, in the reports. I'll direct you there to get more detailed information. And then again here, so this is for total primary brain tumors. You can see the histology groups on the y-axis and the incidence rate on the x-axis. So the most common types of tumors overall are the neuroepithelial tumors, and then tumors of the meninges for females, meningioma specifically. So 64% of patients diagnosed with a primary CNS tumor will survive 5 or more years in this data. 25% will, with a malignant tumor will survive 5 or more years, and 85% with a non-malignant tumor. And then looking at just 5-year survival curves for malignant and non-malignant tumors by sex. So we can see there's a fair amount of variation across the sexes, but fairly good survival still for non-malignant tumors. And then again, broken down by histology. So as I said before, brain tumors are a very heterogeneous group of neoplasms, and this is kind of shown here. So we can see glioblastoma has quite poor survival, 5-year survival. But then we have some malignant tumors like pilocytic astrocytomas or ependymal tumors that have relatively good survival overall. We saw some good survival in the non-malignant tumors, and you can see that even some of the non-malignant tumors have worse survival though than some of the malignant tumors. So that's why it's really crucial for us to get the information on both types of tumors in the cancer registry, so we can really understand what's happening in both of these patient populations and support clinical decision making and research going forward. So just a little bit of a summary. So Brain Tumour Registry of Canada, again, is a surveillance research collaborative with the provincial cancer or territorial cancer registries. So again, it is not a standalone cancer registry. It is an effort to make sure that we enhance existing systems to the extent possible so that brain tumors can be collected, high quality data on brain tumors can be collected sustainably going forward. And we've created so far a sustainable model for periodic surveillance reporting on all primary brain tumors for all provinces and territories. So that is what we're working on right now. We've got a collaboration with the Public Health Agency of Canada to do an analysis of the Canadian Cancer Registry. So we have all of Canada included in our reports going forward. And we will be releasing those as soon as possible. Some delays because of COVID, but moving forward with that as soon as possible. And then finally, ongoing data improvement initiatives. So we have in the bottom here just 3 pie charts. You can see on the far left here, this is initially, so the darker pie pieces are what we would have expected to have been included. In orange, we have brain metastases, so a very low proportion of annual brain metastases would be included in the cancer registry traditionally. Same, we would expect all of the malignant tumors to be there, and missing a huge proportion of the non-malignant tumors. Post the work that we've completed already, we've really improved our capture of non-malignant tumors in the registry, but we still have quite a bit missing. So with the proposed work going forward, if we're able to carry that through, we're hoping that we can capture all of these things so we can have 100% of the non-malignant tumors included, all of the brain tumor or brain metastases diagnosed post primary tumor diagnosis, and again, making sure that we can register malignant tumors molecularly defined, not just histologically defined. So those are our plans going forward, really capture everything, get as much information as we can, and continue to support clinical research. So that's that. And if anyone has any questions, I'm happy to answer them.
Thank you very much, Emily. Again, for anyone who might have any questions, if you scroll down to the bottom middle of your screen, you'll see various options that pop up. The middle chat button is where you can type in any questions that you might have. You can choose to send those privately or to the entire group, and then I can read those aloud for Emily to answer. So we'll give people a couple minutes there if they'd like to ask any questions that they might have. And thank you so much, Emily. What a great presentation. It's we're so fortunate to have you guys working on this, and you are all working so hard on it, and we're so proud to stand behind this.
Yeah, thank you. Yeah, it's a great initiative for sure. We're excited about things to come.
So there are some questions coming in. So is the incidence of brain tumors in Canada higher than in the US with this information?
No, it's not. So sorry, for malignant or non-malignant?
They didn't specify.
Okay, so malignant, no. And if you, there's the one paper that I listed here. So the paper that we published in Neuro-Oncology last year does a kind of head-to-head comparison, adjusting the rates for like age-adjusted rates in Canada and the US, and there is no clear geographic differences. So there's some variation across provinces and states, but in general, we're fairly consistently in the same range. Non-malignant tumors, we're still lower, and that I think is still a function of the fact that we're not capturing everybody yet. So once we're able to complete some of more of this work in routinely capturing the data in the cancer registries, we would expect to see probably more similar rates. But no, at this point, we don't see the rates in Canada being much higher than the US.
Thank you. There's another question of how can patients know if they were included on the registry? Should they ask their health team?
You can. I'm not sure exactly. You could try to contact the cancer registries, but they have a lot of stuff going on, and it's difficult to do that. So I'm not exactly sure. I mean, as I said, it's a passive surveillance system, so it is structured so that it isn't reliant on patients to do that. So there aren't actually established mechanisms for patients to come forward and say they want to be included. And I think that that can be frustrating in times like this when we see that there are a lot of cases potentially missing. But I think, again, going forward, the most efficient strategy for us is to find kind of these kind of data solutions and system solutions to go and get all the data from registry or from information systems that exist and make sure it gets into the registry. So that's where we're focusing our efforts, and it's not, there isn't really a way for patients to come forward and make sure that they're included. But again, so if we can come up with these machine learning solutions for this, we can go retrospectively as well, which is something that we've already done with going back to 2010. We can go retrospectively and identify cases that were diagnosed previously and add them to the registry. And this is something that the cancer registry does on a routine basis anyway. So every time they release data, they will add new cases to the years previously that they found through their quality control initiative. So that's kind of the strategy going forward. And unfortunately, there just isn't really a strong mechanism for patients to come forward and make sure they're registered. You can talk to your physician about it. They probably won't know though, because again, this happens kind of behind the scenes through the diagnosis. You know, the labs might forward the information to the registry. I hope that helps. I'm sorry if that's frustrating.
That's good, thank you. There's also just a comment thanking you for the update on the registry. And another question that says, yeah, thank you so much, Emily. That was a great talk, and the work you were doing is helping to address a huge knowledge gap for Canadians. My question for you relates to the role of clinicians in providing data to the registry. I certainly, as a neurosurgeon, follow lots of kids who don't get surgery. Until you get a machine learning algorithm up and running, how could someone like me contribute to cases to the registry? Also, are there privacy issues with screening thousands of radiology reports? How do you mitigate that?
Yeah, so there are certainly strong ethics boundaries to the way that we would function in that way. So, I mean, we do need ethics approval. It is technically a research study, so it would be heavily monitored, and all the data is again collected in the confidential under privacy legislation in provinces. So all the people who have access to the data, like in order to get access to Statistics Canada data, you go through a really extreme process of vetting, and it's very, the confidentiality boundaries to it are quite strict. So that is just kind of the way that it is for collecting data for these systems, and everybody takes their role in keeping all the information confidential quite seriously. In terms of what you can do as a physician to make sure that the data gets in, again, you could notify the cancer registry if you have a patient that's been diagnosed radiologically that you don't think is getting there. As a neuro-oncologist, I would actually expect that if they visit a cancer center, the data is actually probably getting there. This is the case. I think pediatric tumors are a little bit better captured than adult tumors. So we found that visiting in Alberta specifically, if you visited Cancer Control Alberta Center, or you saw an oncologist, or you had surgery, then we would expect that those kind of flag the system for being put into the cancer registry. If they're seen outside of a cancer care clinic, or not by an oncologist and only followed up radiologically, then those are the people that we're most concerned about. So as an oncologist, I would expect that your patients are being captured.
Excellent. There's also a question, are there any international efforts to compile the information from all brain tumor registries?
So there is NACER as the North American Cancer Registry group, and each province individually reports their data to NACER as well, and that's including everybody there. For broader international, not that I'm aware of, and there have been some efforts to do kind of standalone glioblastoma registries and things like that that cross national boundaries, but nothing else that I'm aware of at this point.
Thank you. Is there any other questions at all for Emily? Oh, can you draw information from brain tumor tissue banks, for example, ours in London?
What kind of like molecular marker information, or?
They don't specify.
Any information. Okay.
I guess so. No, just
yeah.
count cases. No, just
oh, count cases. Yep, that potentially. We don't have any kind of population-based tumor banks necessarily here. We do have one in Alberta. Yes, we could comb through that. But the issue, again, would be for patients that don't undergo surgery, they don't have a biopsy, we don't have any tissue samples for them. I'm not sure that we would be able to add too many of those cases to the registry by looking through a biobank. I would expect that if they underwent surgery and had tissue there, we probably already have them in the cancer registry.
Thank you. Okay, it doesn't look like there's any other questions. So thank you so much, Emily, for taking the time to present to us, and we look forward to future results that that come to be. And thank you again for taking the time and modifying the presentation format to be with us today.
Yes, of course. Thank you very much.